So hello and welcome to our expert panel on population health. My name is Nicholas Torres and I serve in the capacity of Executive Director of the Network Towards Unity for Health. So I'd first like to welcome our expert panelist. Professor Jan de Massaneer is a Belgian family physician and has been head of the Department of Family Medicine and Primary Health Care of Ghent University from 1991 to 2017. His research at the university focuses on health professional education, health promotion, health inequity, primary health care, health services research, and global health. Since 1996, he is a member of the WONCA International Classification Committee, which produced the International Classification of Primary Care, and of the Research Committee of the World Organization of Family Doctors. Welcome, Jan.
Hello.
To introduce Geraldine Bouja. She studied medicine at the medical faculty of Maastricht University and thus trained as a medical profession in an innovative educational manner. After graduation, she worked a few years in regional health centers and hospitals, getting experience in medical practice. Subsequently, she turned to medical education in the context of developing countries. She lived and worked in Sudan and Kenya for several years. Since 2011, she is director of She Collaborates, the International Collaboration Office of the School of Health Professions Education. Her team engages in long-term collaborations worldwide to support higher education in the area of health. Welcome, Geraldine.
Thank you very much. I'm really excited to be part of this virtual symposium. Thanks for the invitation.
And last, I'd like to introduce Tien Hansen-Turton, who serves as the founding executive administrator and director for the Convenient Care Association, the national trade association in the United States of the more than 2,400 private sector retail clinic industry, coined by Harvard professor Clayton Christensen as a disruptive health innovation, serving millions of people with basic health care services across the country. Additionally, Tien Hansen-Turton serves as president and CEO of Wood Services, which is a $230 million nonprofit multi-service healthcare population health management organization and human services organization that provides innovative, comprehensive, and integrated health and behavior education, workforce, and care management services to children and adults in the intellectual and development disability, child welfare, behavioral and acquired brain injury, public health sectors. Welcome, Tien.
Glad to be here.
To provide our participants a little context, I just want to remind our participants of the following definition of population health. Population health has been defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. It is an approach to health that aims to improve the health of an entire human population. It has been described as consisting of three components. These are health outcomes, patterns of health determinants, and policies and interventions. A priority considered important in achieving the aim of population health is to reduce health inequities or disparities among different population groups due to, among other factors, the social determinants of health. The social determinants of health include all the factors, social, environmental, cultural, and physical, that the different populations are born into, grow up, and function with throughout their lifetimes, which potentially has a measurable impact on the health of human populations. The population health concept represents a change in the focus from the individual level, characteristic of most mainstream medicine. It also seeks to complement the classic efforts of public health agencies by addressing a broader range of factors shown to impact the health of different populations. The World Health Organization's Commission on Social Determinants of Health reported that the social determinants of health factors were responsible for the bulk of diseases and injuries, and these were the major causes of health inequities in all of our countries. So in turning it over to our panelists, I'd like each one of you to take 3 to 5 minutes to introduce yourselves, your organizations, and your work related to population health. And Geraldine, would you like to go first?
Thank you very much, Nick. I prepared a short PowerPoint presentation. Let's see if that works. So I'm coming from Maastricht University and I work for She Collaborates, and She stands for the School of Health Professions Education. So we have a research school here only dedicated to find out what kind of education works best in what kind of context. And if you go to next slide, I'll just show you a little bit more of this organization, because the School for Health Professions Education, as most of the schools around the world, they are taking care of the research part. So the PhD program is there. We also have an educational branch that contains the master programs and short courses. Now, in between, we position She Collaborates, because we use both inputs from both branches, the research and the education, to work in international projects in order to improve healthcare. Below you see a picture of my team, who are only dedicated to the international projects. So our mission is to improve healthcare globally by choosing the line of educational reform. And that means educational reform in the sense of methodology. But of course, you can't talk about methodology without any content. So we are always content related in the area of health professions. Then you could call us more like a knowledge broker, maybe, because we seek for the right expertise within our network, and the closest network is Maastricht University Medical Center. But also across the world, we have built up our network, and we look for expertise that can help other universities or schools for higher education one step further to their ambitions. In our portfolio, we have various projects, so it's not only on medicine, but it is also about water and sanitation, about sexual reproductive health, nursing, health information management are just some to mention here, but it covers all health professions. So here you see a map of where we are working actively right now, and actively then I mean with a really long term, more than 4 years, sometimes even up to 20 years collaboration time, because we believe that if you talk about reform, you cannot do that by just a single workshop or a very short period of time. You need to build trust, you need to understand the context, and that takes time. And here you see what we offer. We talk about change management and project management, which is sometimes in an academic setting a bit a strange area, because people are focused on research, focused on their content area, but not so much on the change management. And we work specifically on capacity building in the area of health professions education then. So I took just out of our list of more than 40 countries where we work now, a few examples that I think are more relevant for this virtual symposium. Because for instance, in Kenya, we work to support the master program in family medicine, which, and I'll come later to that, is a kind of collaboration in the health population health, sorry. In Ghana, we work in schools of hygiene, so it's completely different, but again, an important element of population health. In Sudan, we talk about nutrition and how can you grow rich crops, and how does the population know what kind of food is really for them the best nutrition to take on. In Indonesia, again, it comes close to primary care, and how can a family physician support population health in the whole of Indonesia. And in South Sudan, we are again working in the area of health and sanitation. So I just took an example from my colleague in Kenya, which shows, I think, the comprehensive approach of health professions education in combination with population health. I believe you all know this picture, and as you can see almost in the center, you see the social and economic factors determine about 40% of what is the health outcome. So we have to take that into our education somehow these days, because if you only talk about clinical care and about really knowledge and skills in a clinical or medical domain, you are not going to make the real difference. So in that project in Kenya, this is the definition of population health, which comes very close to, Nick, what you already mentioned in your introduction, where the determinants of health come in very strongly. And this is then an overview how you could look at it, in which you see that in number 1 at the right top, insurance plays a role. In the second picture, you see community plays an important role, and the screening and the preventive measurements take an important role, including the primary care, of course, and a good referral system. And that, in the end, improves your family's health and wealth. another beautiful, I really put it on here because I love the picture so much and there's so much to look at, and I don't have the time to explain much more now, but I believe you share this with the audience later in the recording, so you can really take a close look at this map of the integration of all factors that improve the health and the wealth in the population. So far, thank you for your attention, and I give the floor now to one of the other panelists.
So, John, would you like to go next?
Thank you very much. My background is that I'm a family physician. I worked at Ghent University, and here you see me writing a proposal in the framework of the health systems network, working at the report of the Commission on Social Determinants of Health. And the point that we wanted to make was that good primary care is essential to address the social determinants of health and to create health for all. So that's a little bit my background. I went through a life together with my wife Anita, who is now retired psychiatrist and actually active as council member for the city council as a Green politician. So we are very committed to societal change and climate. And these are our 5 grandchildren. Of course, being a student was for me a really important start. Already as a student, I was involved in change management, changing the curriculum, changing the health structures in order to base them more on the principles of solidarity, equity, and to make them more relevant for addressing the needs of society. Next slide. Next slide. That was the slide on my student time. Next slide. And of course, I started to do my practice in Rwanda. And that was a very interesting experience because I could see there how social determinants of health really impact the outcomes in terms of mortality and morbidity. And for me, that has been a very inspiring phase in my career because that inspired also the way that we start later on to work as a family doctor in a community health center. What we did, we brought all the traditional health disciplines together in one building. I'm sitting actually in that building. These are contributors, family doctors, nurses, social workers, psychologists, social workers, dietitians, nutritionists, all kinds of people working together, both addressing individual and community needs and working together with the local population. Because the focus of our work is the defined population of a community. We work actually in what has been 40 years ago the most poor area of the city of Ghent, with 10,000 people living on 1 square kilometer and actually coming from 107 countries. So that's a very diverse place, and this of course has an influence in the way we try to deliver our primary health care. And we also tried to use that same principle of strengthening primary care and capacity building in Africa. In 1997, we started with the Prima Famet network, and actually we support training programs for capacity building in primary healthcare in 20 African countries, working and linking with 35 different institutions for health professional education. And of course, a lot of those institutions are members of the Network to Unity for Health. In the meantime, I also became active at the level of policy advising. I actually chair the expert panel on effective ways of investing in health that advises the European Commission on health matters, and we try to make a difference there in order to bring more equity also, not only in Europe, but also to address the problem of the refugees by investing in capacity building in the South, because I'm fully convinced that if we don't invest in capacity building through South-South cooperation, strengthening primary care, but also strengthening education and strengthening agriculture, that we will never solve the problem and address the push factors that make people moving and migrating to the north. And of course, climate change will be an important determinant of that evolution. And now I come back to the city of Ghent, where we are actually starting with a new project. We have a primary care zone, and the population of the city, being 240,000 people, is the population where we want to bring population health. So what we are going to try to do is to make a community diagnosing, looking at morbidity, looking at all social determinants of health, ecological determinants of health, and then making interventions in order to address the upstream causes of ill health. And in order to do that, we bring all sectors together. These are people from welfare, from mental health, from all kinds of sectors, from school, and that work together and make a community diagnosis and try to find out ways to improve the health situation. And that policy actually is in the whole Flemish region, which is 7 million people organized. We have something like 60 of these primary care zones that all are taking care of a population of 100 to 120,000. And that is our population health focus. So primary care zones also are now actively in other countries. They are starting in Ukraine and in Estonia and also in Scotland. And if you are interested, I wrote what I learned in 40 years in this book that's still available, but I try to reflect on how we can integrate population health and individual health care. And I think that that mix is what really matters for the future. We have to bring individual care and population health together in one integrated approach, blending primary care with public health approaches. I think this was it. Thank you.
And Jean, we'll turn it over to you.
Good morning. From my perspective here in the U.S., just a little bit more background on me. I came to Wood Services about 2.5 years ago, and I'll talk about Wood Services. But my premise, really before that, I spent probably 25 years on really, in both in the U.S. and also globally, working on primary care areas where there was primary care shortages, looking at different kinds of professionals that could sort of fill that void. In the U.S., we have had a primary care physician shortage for almost 50 years, and it's not changing. So, this was a country where, we started to have nurse practitioners move into that role. And I would say we're seeing that more and more globally. So I've worked with a lot of providers around the world, both in the policy environment, but also coming up with various models of care, how to get people access to primary care as a foundation for coordination of healthcare services. About 2.5 years ago, I walked into a very unique and incredible organization called Woods. And just very briefly what we are, we're a multi-service population health and advocacy organization that provides a lot of innovation services around integrated healthcare, education, housing, workforce, behavioral health, case management services for very complex medical compromise, genetic and behavioral disorders for people that have intellectual disabilities. That's a mouthful, but essentially in the population we serve have lifelong needs and have complexities because of their disability, intellectual disability, that just compounds the challenge of providing care for them. So essentially, I would say we are an organization that do healthcare and also provides the social determinants of health to provide support for the population. So just after the mission, okay, so just to give you a sense of the complexity of what we who we serve. So the people we serve have severe physical challenges, complicated medical conditions, neurological disorders that requires a different level of specialists, brain injuries, autism. And when I say autism, we don't serve high functioning people with autism. We serve autistic as children and adults that have self-injuries behavior or may have explosive disorders on top of autism. So think about very complex people. Development disability, of course, and I would say complex emotional behavioral health disorders. So the whole connection between physical health and the sort of the body and the mind becomes key to our population. And then we also do family services and mental health and some drug and alcohol, because all of that somewhat is related. So here, I would say the Woods Life Continuum of Care is almost, if you just look at the leaves on this tree, you'll see many of the social determinants that Nick talked about in the definition of population health. We essentially provide all the wraparound services from 24/7 housing, whether it's in a more residential facility or whether it's in a community home or at home, in rental units. We provide 24/7 care. We do dehabilitation for our adults who we serve. Will not necessarily have a job, in the private sector or in the public sector. As we think about it, they might have part-time work, or assisted work, whether you have, workers that work with them as they actually are in the community. Lots of behavioral health, residential support, vocational training, physical, and also behavioral health, and then education for our kids that are under 21 years. So uniquely to us is that we provide all the services on a continuum of care basis to the people that need it. So, I'm not going to go through all these programs, but you can if glancing at them again, those are the services, that are behind really those social determinants that you need to provide care for. And what's unique about Woods compared to probably other providers in the U.S. is that we do everything under one roof. We're also a large entity, so we're able to do that. But it's all about integration. And, for those of you who are in countries where government do more of this work, we are what's called an NGO, a nonprofit that provides all those services. And that's very common in the U.S., that the nonprofit community is sort of the bridge between the private sector and the government sector versus many other countries. I'm originally Danish by background. In Denmark, it would be the Danish government providing these services. That's not the case in the U.S., where it's always usually done by NGOs. And I think what's unique about that for this perspective is that we are able to be creative. We're able to bring lots of funding streams and service streams together and make sure that what's often silos, providing care for this particular population, we can bring that together and really provide that full continuum of care or services and address all the social determinants and challenges that the people with intellectual disabilities face. So a little bit about background, I think that's important from my perspective, is just what's the trends. I won't bother you too much because this is sort of an American terminology, but essentially we provide care to the most costly government-funded population and 24/7 care. When you look at our spending, which is public spending in the U.S. is called Medicaid and Medicare, we account for about a third of all the public dollars in healthcare services, yet it's only a population around that's about 7%. So a small population that costs the government because of the complexity about almost a third of the healthcare spending. So again, that's why we require sort of unique ways of providing services to them. Issues with this population has really been the barriers to access to care and the health disparities or health inequities that you heard my other colleagues speak about. Traditionally, the population, when you deal with very, very complex people that have medical and behavioral needs, providers, are leery taking care of our population. And part of the reason is that they take a lot more time to provide care for. So, for example, a typical primary care visit may take up to an hour versus in the U.S., where it's no more than 15 minutes. And often, providers don't have the education or the knowledge about really addressing both communications and behavioral challenges. And I usually give the example, when our clients go to a primary care visit, or whether it's in the community or here at Woods, where we have a large health center, they may need to be seen out in the waiting room or in the van that transported them just because they have behavioral health issues, or they may act out because they're scared. So there's triggers and they can act out, which makes it extremely hard for sort of just barriers to access in general. They can't just go and get access in the community. We really need providers that understand their disability and how that manifests itself in terms of how they're taken care of. In terms of health disparities, that's not the case from Woods, but traditionally people with intellectual disabilities of our, I think, magnitude have had shorter life expectancies, higher rates of co-occurring issues and sensory impairment, higher rates of epilepsy, psychotic disorders, and they also might experience a lot of undiagnosed diseases just because it's still there's still a lot to learn about the population we serve. They have higher rates of emergency room utilization, often because of psychiatric reasons, and they often get admitted to a hospital visit versus really not needing that services where others might not be. And they also have lower rates of immunization. So lots of health disparities for the population. So, again, we are organized just like our, around the principles of population health management. And our philosophy is that idea that, if not us, then who's going to take care of the full continuum of care and services that this population need, both from healthcare, prevention, education, and so forth. We address the whole person, and I'll talk a little bit next about our care model. I think this is important. So our care is for the whole person. What do we mean by that? That really means that when you have a complex population like this, there needs to be a team around that person. So we often start with an individual care coordination plan. So we determine what are the needs based on the individual challenge or opportunity that a person with that intellectual disability have. What are the issues? How do we actually create a complete care plan so they can live, to their best ability? To do that plan, we have care coordinators, and we sort of have a team of social workers that work more on, the social determinants challenges, what are the education, the workforce, housing needs, and then we have a nurse navigator, that can be anywhere from an LPN, which is, an associate degree to a master's or doctorate degree in nursing, depending on sort of the acuity. So we also use, nurses and nurse practitioners in that role. The point is that both the nurse and the social worker function as in the social determinant and also the healthcare navigation person to make sure that everybody gets the services that they need. Most of the staff that we have are direct care staff, so that's 2/3 of our workforce, and we have about 6,000 people are folks that are unskilled or sort of think about community outreach workers. They are there 24/7 with the people that we serve. Sometimes we have one-to-one, but sometimes we have 2-to-1 staff, just to sort of make you understand the acuity of some of the challenge behaviors that we see with our population. And then we, in terms of healthcare professionals, we have nurse practitioners, physicians, physician assistants, psychiatrists, allied health providers, and specialists. So really a comprehensive care team around them. Some of that services are here at Woods, or it may be, in hospitals or in community settings. So the services we do is, again, the personal care plan really drives both the services that we provide from a healthcare perspective and all the addressing the social determinants. And those could be housing, education, employment, assistance, safety, and really a quality of life. Then we have, primary care, and we employ what in the U.S. is called patient-centered medical home, which is, much more of a care coordination, wraparound, in a primary care model that addresses, again, a lot of the complex needs of a population of our type. And then we have a lot of pharmacy and medication management and behavioral health.
It feeds into our next question, and maybe to get Jan and Geraldine's perspective on part of this idea of population health is it's moving beyond just one person, really this health team. So I was hoping that maybe John and Geraldine, you could expand upon, how do you broaden and strengthen the health team from the community health worker, indigenous health worker, many names out there, nurse navigator, nurse practitioner, midwives, and towards how do they participate in this health team towards universal access and equitable healthcare? So maybe Geraldine, would you like to start?
Yeah, well, if I take it again from the educational perspective, yes, we have a lot of differentiations now. We have many more healthcare providers who act in between, like the patient and the hospital care, so to say. Our concern is how can they collaborate? How can they make sure that they cover the needs of the patient? And taking it from an educational perspective, we are trying to figure out at what time in the curriculum which students you should offer kind of interprofessional training opportunities in order to learn competences like collaboration, teamwork, leadership, because in the future healthcare professionals, this is more important even than just knowledge, I would say. Knowledge is something that you can look up in any kind of application, computer, whatever, provided you have mobile connection via your cell phone or internet. But that is almost everywhere. It can take a little while, but you can get it. But the soft skills, the competencies are such harder to train. And also because there's not so many examples yet in the world. You cannot say just go and look there and then you learn from them, because what they see is mainly like the old-fashioned practice. So we are struggling here in Maastricht to find the right moment and the right combination of people to train future health professionals in collaborating, working together really to solve the complex, multi kind of problems of the, not only patients, because mainly you want to be earlier working with them earlier than at the moment that they called patients, but with the population, with the people.
Thank you, Geraldine. And Jan, would you like to continue? And I think you want me to bring up the other slides.
Yes, you can put up the slides on community-oriented primary care, because I want to explain that at the level of a population, as primary care workers, nurses, social workers, community health workers, you have family physicians, you have a lot of information in your daily practice. And the challenge is how to use that information. So community-oriented primary care is exactly starting from the individual encounter and looking what are the determinants behind. And what we have learned, this is the approach. You start from a community, you define the community, and community is always the population in its diversity. You bring together relevant information. It can be information from the medical records, of course, anonymized. It can be information from surveys or from population censuses. You make together with the community a community diagnosis to see what really matters to the people. You develop together with them an intervention, and then you monitor the impact of the intervention. So continuously you develop, this model has been developed by Sidney and Emily Clark in the 1940s in Porela in South Africa. So you can learn a lot from the South. And what they did, they looked in their practice to what were the determinants of health, what was the prevalence of certain problems, and the health center was the central point. And that was what inspired later on the issues of the primary care model that in 1978 was embraced by WHO in the Alma Ata Declaration. So it's a continuous process. You come from the community health process problems, you go to develop intervention, you monitor, and that feeds back into the community's characteristics. And in each of the steps, you involve the local community next. And for instance, we saw in our consultation that our children were in a bad physical condition, not in good shape, not a very good muscular development. So we made the survey, and we saw that the children in our community were 2 times longer in front of television, video games. It was in the 80s, and had less physical activity compared to the actual youngsters in our society. And so we brought all the stakeholders together, the youth organizations, the schools, the parents, and we made together a community diagnosis. And the fact was that we live on 1 square kilometer with 10,000 people. So there was a lack of playgrounds. There were no playgrounds at all. So that was not difficult to make a community diagnosis. And then with all stakeholders, we started to take action. And the action was not to prescribe medical things or to prescribe vitamins or physiotherapy. No, that would be nonsense. The action was to construct playgrounds. And with a group of volunteers, we constructed playgrounds in the local community, organized activities during holidays so that there was possibility for children, well, to really develop. And we made an assessment of this intervention. What we saw in the evaluation of the intervention, first of all, the police reported a decrease in the street criminality by youngsters. That was an outcome that we didn't expect, but that also illustrates that social cohesion is a very important outcome indicator. And so this was for us a very positive sign about what the impact of our intervention was. Secondly, we saw an increased social cohesion between the different origins, ethnic cultural minorities in our community, Turkish people, with Belgian people, with people from Africa, and so on. And thirdly, we saw an increase in an improvement in the physical activity. So from the simple consultation with youngsters towards this process of community diagnosis and making interventions that address the upstream causes, that is what we did. And of course, it was not only an action by individuals. The city then took over this initiative, and actually we still have 7 playgrounds in our community. And that are really the green spots that bring youngsters together. And this illustrates the partnership pentagon that the Network to Unity for Health has developed, and where you have to bring together the policymakers, the health professions, the academic institutions who did the survey, the local communities and the representatives and the health managers. And I think that this is very important in order to build health systems based on people's needs. So for me, population health is starting from the problems that you see in your daily encounters with people, bringing this to a community diagnosis, looking at the upstream causes, and then involving everybody in making change happen, addressing the upstream causes. And that's what we did in the last 40 years here in the local community and contributed to improvement of health.
So thank you, Jan. And maybe, Tien, you could maybe expand upon what John was saying in terms of health professions and, the work of the nurse practitioners in the United States. I know you're working with Denmark in terms of looking at nurses also, and also in Australia and New Zealand in terms of nurse navigators, and maybe expand upon their particular role. And there is a question in the chat box about pharmacists too. So maybe you want to incorporate that into some of your comments.
I mean, I think I think Geraldine is right in terms of, just talking about the challenge of the team. What I've found, and before I talk about that, I'll talk a little bit about at Woods. I feel that, we have the team, the comprehensive team that everybody wants, but it's really retraining everybody once they come here. It's not, the leadership and, I would say the knowledge is not there to work truly as a team, but you have to do that when you deal with a very complex population. So I think that we need to find better ways to do it. And it's hard for a company or an organization to do that. And I would say a lot of people don't come prepared. And I think that's a real challenge with us. So I totally agree both with Geraldine and John. So in terms of, so I would say that, I think that the most important thing I've learned over the last 25 years, and I'm not a healthcare professional, I'm a person that had worked more in policy and worked with various non-physician providers over the years, is really the need for us to look at how do we maximize the role of each provider. And I would say that, nurse practitioners, I think have played an incredible role and continue to play an incredible role in primary care. There's all kinds of care gaps, and there's all kinds of needs of connecting people to care between providers. So I think what's key is to find those providers that understand that. And I've found, at least in my career, that the nurse practitioner role is key because it's an advanced practice nurse that also understands primary care. So that connection point, but also as a nurse. I would say the same thing on pharmacists. Pharmacists have more, in the US, have less authority than they do in Europe, for example. So they can't do prescriptions. They really can't do that. Well, they do some management, but primarily their role has been underutilized. So see, that's another provider that if you can get them part of that care team that understands, medication management, which is, if you do that right, it's a huge cost saver for any country when it comes to healthcare costs. The biggest worker though, and I think the biggest need though is really to train the allied health workforce or the community workforce. And I think that's from a population perspective, there are really no good training programs. And I mean, we take in the US people straight out of high school or that have no skills whatsoever. And yet, we train them in a curricula, et cetera, and then, expect miracles from them. And I think that, how do you integrate them then with the professional team? So I think there's lots of needs in this world, and certainly in the US, for figuring out, how do we integrate all the people that, that are the service team around very complex, people that have population health needs. And when we crack that code, I think, you'll see better health outcomes globally.
And to react on that, Tine, what I see when I travel the world and medical schools ask our advice to improve their medical curriculum, the question basically is then, how can I make sure that my graduates will pass the USMLE or like these kind of tests, And that is so much knowledge-based, and that will not solve in the end the problems that we are facing. So to make that indeed that shift of thinking, that you have to start working as a team, interprofessional, but even with outside the healthcare team, like Jan's example really showed how many people come on board to improve the situation around playgrounds. Ask any medical doctor in training, and they say, but I need to know this knowledge, otherwise I can't pass my exams. So there is a lot of work to do there still.
If I can add to that, I think this is really essential. In our undergraduate training programs, and Nick, if you can pass the slides again, I will give you one example, what we do in the second year. So where are all the students now? Well, they are in the community health center. And that's what we do. We train them not only on campus, we bring them in the community, and you see them there. What we do is we bring them together, and the first thing they have to do, they have to prepare an interview with a family living in poverty or living in distress with a disabled child and so on in the community. So they prepare to go and to visit that family, and then they get an introduction on the context, the history and the background of the community, so that they can look at the social and historical determinants, because without that you cannot understand where and how families are living. And then what they do is they visit a family living in poverty, and then they are going to talk to 3 care providers that are involved in the care for that family. And so they see from both perspectives what it means to live in poverty and to live difficult lives. They bring all this information together from all their visits, and they try to make a community diagnosis. And we do that with students from 5 different training programs: medical students, nursing students, health promotion students, social work students, and pharmacy students. And they sit together and they make a community diagnosis already in the 2nd year of their undergraduate training. And then they discuss, and that's an interesting interprofessional clash of culture. On the left-hand side, you see a health promotion student, on the right-hand side, a medical student. And they have different viewpoints, and they learn from each other how to look at social determinants and to look at social problems. By the way, on the left-hand side, you see Alicia Kempeneer, who is working for the network. And so then they make a community diagnosis. They look at the different problems, and they look at what could we do to make life better in this community next, using also epidemiological information. And then they prepare a presentation where they are going to give feedback next to with their findings to the community. And the idea is that we can prepare the students by training in that way, so that they later on will take a seat in the community platforms and take up their responsibility in order to respond to the social accountability of the training program. So it's really important that we prepare. And some of the students told us that it was in that experience, that is 1 week experience, that they decided to become family doctors, because that was the way they could deal with the skills and with the needs of the population. Thank you.
So and this kind of feeds into a little bit the next question. So maybe going back to you, Tien, and as you look at the community, and it also gets into governmental policymakers, maybe there's a push to say the way that the health team is recognized in the formal environment of government is through some type of criteria or standards that recognize them as a formal part of that team. And I was wondering, maybe you can talk about sort of, from your experience, what type of criteria or standards are we looking at for community health workers, indigenous health, nurse navigators, and such? And there's also this component that a lot of the participants are asking about data. How does community data feed into that whole concept, and how is that utilized?
Sure. Yeah, I mean, so I would say it's easier with the more professional. I mean, the more professional education, I think, the easier it becomes. But I would say that there's some basic things, and again, it's got to be outside the education system, because I go back to, I mean, Geraldine is right, and I think Jan, I think I like the integration. I see that in the U.S. too, in some of our certainly medical education and nursing education. But when it comes down to it, it's not what they come out with. It's not on a test, not on an exam. And often when it's not on a test and not on an exam in the U.S., I find that it doesn't get necessarily taught to the fullest of its ability. So I would say that certification programs is key. We've done some work more on the community health workers. In my previous work, I worked with nurse managed clinics around the country, in the U.S. and also globally, and we essentially came out with a certification of what it meant to be community driven. How do you address what are social determinants? So it almost was a test around how do you actually educate people about the community, and I think, Jana, your example of what it takes to do playground is perfect, because I've been in those situations in underserved areas in the U.S. and urban areas. It takes a village, if not more. So and how do you put that into a training program? So I think, Nick, it can be multiple things. It can be sort of some education around the community in a certification program is certainly what we've seen, but it can also be curricula. So I would say with lay workers and lay workers meaning folks that are not skilled or don't have a university degree, we do a lot of training around the populations that we serve, whether it's in certain curriculums, whether it's asthma in some diabetes, or in our case, where it's dealing with a person who has behavioral challenges and also severe developmental disabilities. But I would say that what we probably need to do more of is figuring out what are the competencies, collectively you need for special populations. And I think this is an area where we can work a lot more globally than I feel that we've done in the past. So certification, standards of care. What we did in the retail clinics, I think, was really key. We defined in retail clinics in the U.S. was a solution to a huge primary care shortage, not for the poor, but for sort of the the working class and the middle class that couldn't get to primary care and would end up going to the emergency room and not go at all, which is not smart, because primary care, from my perspective, is really the connector to all areas of healthcare and population health. So what we did with the retail clinics is we came up with standards, and we said, what's a retail clinic? What are the outcomes we want to get? What are how do we actually what quality metrics do we want? And that worked very well to the point where NCQA, which is and also Joint Commission, which is our accrediting bodies, picked up what we had defined as care for people in the basic primary care and retail setting. So I think it's not hard to do it, but I think it's partnering when it comes to population health, is partnering probably across countries, because I think it becomes more complex in primary care. That's just my perspective.
Geraldine, would you like to just add to that?
Yeah, well, my thoughts were going into this area of interprofessional education. What we know from research is that it doesn't really work if you put students from different backgrounds, different training programs together in year one, for instance, and with the idea then they learn to interact, they learn to listen to each other, they learn their different contents of their professions. We know by research that it doesn't work. It helps maybe even in contrary, because they feel like I'm better than you, or you don't understand the problem like the way I look at it, and so on. So what we now do, and what we learn that is useful, is that you give them an authentic task. If they really need each other, then they have to respect each other's background, and then they start learning. So if you move it to a little bit later in the curricula, where they already have a better understanding of their own position, of their own capabilities, of their own training program, then it starts they start to appreciate what the others are doing. So and giving them an authentic, a real task, so not just a paper kind of idea, but maybe Jan's idea of this playground development. Give them, this is the data, this is the problem, what would you do? Or give them really a real patient and a multidisciplinary approach to a real patient. Then they start learning from each other and collaborating and developing skills like listening, like reasoning, like collaborating, team-based, and so on. So from the educational perspective, it's very important. We have to fight all the time this knowledge-based exams and kind of systems that push programs into knowledge outcome instead of other competencies. And the other thing from the educational perspective is that if you move this integrated care, integrated approach to the years of their programs, it works better.
If I may add to that, I think it's an end-to-end story. If it goes about learning to see the social determinants of health and the importance, you do it better early. Because of course in the 4th and 5th years, the doctors are already doctors and they think that they know everything. So that's a difficulty. In the 2nd year, they know that they know nothing. And the nurse and the doctor, and so they are all at equal basis. And as Geraldine said, you touch on issues that are not medical, that are not clinical. You touch at the upstream causes which are social. It's about loneliness. It's about access. It's about playgrounds. It's about this kind of things. Later on, and then I agree completely with Geraldine, if it is about learning to work together, you have to do that in the second part of their training and in the postgraduate training, because there they are all together. And I think there you need other ways of approaching it. And I agree, attitudes are extremely important. And behind that, financing systems are key. As long as you continue to pay doctors 5 times as much as nurses and other health workers, it will be difficult to work together on equal basis. Let's be serious about that.
Thank you, Jan. So we have time for one last round, and so anything that that you want to add to this entire conversation, and also maybe hopefully you can integrate. Part of this is how do you get governmental policymakers to take many of what you've discussed today and incorporate them into local, regional, national, or in many sense global policy that sort of adopts many of these best practices. So maybe Jean, would you like to start?
Well, a few things that I like. One of the questions, by the way, on sort of the chat, which talked about how do you get ordinary citizens involved in this, and I would say that I call ordinary citizens consumers, or population health, or whatever healthcare consumers. I would say consumers drive most of that. I would say in Jan's example of the playground, I've been in my own kind of playground situation. It was the community that drove the need for change. In the retail clinics. We started very early on with some basic healthcare services. It was the consumers and the users that they said, hey, listen, this is a model that we want to expand, open up your services for more. And we initially early on, we did not get reimbursement. In the US is all private, primarily private insurance or public insurance. So we did not take in these clinics, private insurance, but it was the consumers again that said to their insurance companies, hey, we want services to be paid for in these clinics. So I find that the role of the consumer, we can't forget that. It's in all of this conversation. So I like that question about citizens or consumers. In terms of policy, that's where it's all at. So I think that I think that this is a global discussion. But what I've at least been successful with our teams have been sort of systemically going through and changing policies to allow for collaboration. I think Jan is spot on. It's going to be very hard until decisions of there's more equal pay. As long as there's somebody gets paid more, there's a power imbalance there. That is a challenge. But I would say that opening up sort of regulations in each country to allow other providers to be part of the team. So let's talk about Denmark, where I grew up. The nurse practitioner role is just being introduced, which I'm embarrassed about. I mean, this is a very liberal country, and they are just starting with the nurse practitioners versus the U.S. that have had nurse practitioners since the 70s. So I think part of this is systemically going through countries and looking at what are their, how do they regulate currently the various professions, including allied health professions, and are the regulations open to allowing people to practice to their full scope of education, so you can actually maximize what they bring to the table. I think that's first, you need to do all that first before you can really address some of these, barriers to, I think, public and population health. I mean, that's where I come from. You've got to fix what's not working. You've got to fix the power imbalance that we see in all countries when it comes to various professions. And then you can really begin to figure out, what are the funding you need for this care team to wrap services around people in the community.
Thanks, Geraldine.
Yeah, if you talk about policies, then in the educational approach, you really would like to see that the exams and the way you are going to grade or decide whether a graduate is ready to graduate should be all inclusive again. So not only knowledge, but the same as the integration of population health, you need also integration of other competencies in all of your curricula. And so if you can change the policy into a different assessment system and this graduation system or degree kind of providing system, we really will be a step ahead, a step further going to this kind of integrative care opportunity. But as long as the policy is going to not to reward this kind of development in people, we are not moving.
Thank you, Geraldine. And Jan?
Well, first of all, I think we should emphasize much more generalism in all disciplines, in medical disciplines and in others. And I think that the family physician who is a generalist at the primary care level is essential together with nurses and social workers. So in our training, puts a focus on generalism. And that's needed also because in the future, the mobility patterns will change and you will need people that can think transversely. And that's what generalists can do. Second, if we want to be serious about strengthening primary care, we have to put more money in it. Actually, most of the countries have something like 12% of their health budget going to primary care. It should be at least 25%. And you need money and financing systems that stimulate the right approaches and the right attitudes. And so an integrated needs-based capitation for the different team members in one lump sum stimulates cooperation, stimulates task sharing, stimulates also self-reliance and prevention. And I think we have to think about that. Horizontal integration of financing is extremely important. Third, integrate health and social care. If you want to take seriously the importance of social determinants, you need to integrate health and social care into one coordinated approach. Fourth, integrate primary care and population health and public health, because this is where you have to blend, on the one hand, the approaches of the individual clinical care with the approach of the population health. And this concept of community diagnosis links the individual activity to the broader population orientation, and then you can look at outcomes in terms of increased quality of life and increased satisfaction, and finally increased happiness in the community. And lastly, all this is needed in order to create more equity. We live in times today where solidarity and equity are really under stress. We see that there's more emphasis on building walls than on building bridges. I think that healthcare, and especially primary healthcare, has a role to play in order to contribute to more social cohesion and solidarity, because that's what our societies need in order to make and to build a sustainable future.
So, well, thank you so much, John. And I want to thank all of our panelists, Tini, Geraldine, and John. Thank you for spending your time with us. With that, I would just like to say thanks to everybody and enjoy the morning.
Thank you very much.
Thank you. Bye-bye.